Thank you. Good afternoon. And this is kind of deja vu day today because I was earlier today. The D&P students at Tech are presenting their capstone presentations, and some of you may have been there to support some of the graduates there. And so it was just like deja vu. Like 5 years ago, I was there, standing in that same position, doing the same thing. So I kind of feel for them and really see. And I'm not nervous. They're nervous, but I know exactly how they felt. And so I'm here today to talk to you about my project that I worked on during my D&P experience. And the title of the project was Implementation of Charge Nurse Handoff Effectiveness. And so we'll go on from there. The purpose of this is a quality improvement project, and it was conducted to improve charge nurse communication through standardization of the charge nurse handoff using team steps and SBAR communication strategies. I didn't want to look at the nurse-to-nurse handoff because that's pretty straightforward, but what was different was looking at that charge nurse handoff. What's different about that, and what are those particular things that needed to be done with that charge nurse handoff to make it more efficient and more effective. So the significance of the situation is that this project is significant because handoffs are a means of transferring essential information. And that essential information is fundamental data that's needed to provide safe patient care. And what it's included in the handoff varies from setting to setting. And it should include a summary of the patient's current medical status, resuscitation status or code status, recent lab values, allergies, a problem list, and a to-do list. And this is from the Joint Commission. Quality of the handoff is dependent on the skill of that person giving and receiving the information. And effective communication is challenged by a lack of consistency in that handoff process. The Joint Commission requires standardization of the handoff process, and standardization of the charge nurse handoff ensures that continuity and safe transfer of patient care. And knowledge of essential elements ensures that safe, accurate, and efficient transfer of that patient information. So some of the background in looking at different handoff delivery methods, there are many. When I was doing the literature review in preparation for the project, was that I found these various types of delivery methods. Verbal, report at the bedside, audio taped, and at that particular time there were still some units doing audio tape, which was very alarming to see. Telephone, written, nonverbal, electronic records, computer printouts, and memory. So from the literature, 3 methods of handoffs were analyzed for information retention. So looking at how much information are you going to retain from that report based on the information. So the methods demonstrating the greatest amount of information retention included a pre-printed sheet with patient information and with the verbal report, note-taking and verbal report, and then verbal only. With 96% to 100% information was retained when using that pre-printed sheet containing patient information and verbal report. So the verbal report, having something that's all verbal but also having a sheet there helps with the retention of information. So you need more than one method. Other things to consider regarding handoffs involves examining the impact of the system factors, and that includes the organized and coordinated methods, the procedures and protocols that are in place. Also looking at human performance, and that focuses on the behavior and interactions with the environment and the organizational culture, and then looking at structured protocols, and that's the standardized process and tools that are going to be used. So let's take a look at each one of these areas. So when we look at systems factors, the literature showed that interruptions and distractions during handoffs create confusion and variance in time of report, resulting in increased labor cost, as you can see there. When you look at human performance, the literature shows that the handoff process is ritualistic and that verbal report helps to debrief. Success of the handoff is dependent on the skill and comfort level of the person receiving and giving patient information. And we'll talk a little bit more about this particular area a little bit later on. And when additionally looking at human performance, also that face-to-face handoff is preferred to allow for opportunity to ask questions. When we look at structured protocols, the literature showed that the Joint Commission requires a standardized approach to handoff communication. Also, that the use of SBAR communication of essential patient information to enhance patient safety. The preliminary study, talking about how the study was set up, that was conducted to address issues associated with handoffs and identified the following problems. That interruptions did occur by staff and the phone. The location of the report was not isolated from the staff, and the use of audio taping by one unit increased the time of report and did not allow for questions. And that essential information, such as code status, was not routinely being reported. As a result of that preliminary study, it led to the development of the study question. What is the effect of implementation of a standardized charge nurse report on transmitting essential versus non-essential information and total report time compared with the charge nurse reporting current charge nurse reporting methods? Theoretical framework used was diffusions of innovation. And diffusions of innovation explains how innovations are adopted in a population and are influenced by the ideas, values, ease of use, and implementation and results. In this project, diffusions of innovation was used to determine the need and interest for change, guide the development of the revised charge nurse report tool, and support development of training, implementation, and observation of the tool, and determine satisfaction with the report process. Team steps was used since it is an evidence-based systematic teamwork system and aimed at optimizing patient outcomes by improving communication and teamwork skills. It includes a comprehensive training curriculum to integrated teamwork principles. And then SBAR communication. And this was is a strategy to provide clear, accurate communication. SBAR is a technique requiring immediate attention and action concerning a patient's condition, and it includes S, situation, B, background, A, assessment, R, recommendation. The setting for the project was 3 medical surgical acute care nursing units at a large urban hospital. The population sample included 19 charge nurses on 3 medical surgical care units at a large urban hospital. And approval for this project was through the Institutional and DNP Program Committee. Looking at demographics of the study group, the gender, they were mostly female, 84%. Ethnicity, mostly white, 68%. Educational level, 47% had a BSN, 37% had an ADN. Looking at years of practice, you can see here 37%, the tallest bar there, were in practice as an RN 0 to 5 years. Years as a charge nurse, the tallest bar there, 47%, or 9 of them were in practice 1 to 5 years in that charge nurse role. So very new charge nurses. Time in the unit, time on unit in years. 57% of them had been on that unit for less than 5 years. And in that charge nurse role, 74% were in the regular charge nurse role. Most of the others were serving in a relief role. Methods used, the charge nurse report tool was developed from the data collected from the preliminary study to include the essential patient information such as code status. The new charge nurse report tool was submitted to the charge nurses for their input. The report went through 4 revisions by the charge nurses before agreement was reached on the final report format. Three 5-hour classroom sessions were conducted to teach team step strategies and SBAR communication to the charge nurses. And then after that was implementation of after the training, then implementation of the new charge nurse report tool occurred through 39 observations of the charge nurses using the tool on the designated nursing units. And then a pre and post implementation survey determined the perceived need for change in the report process, and the satisfaction level with the new report tool post. So did a survey pre and post as well. After the observations were completed, a data file was created and organized for analysis using SPSS 18, looking at descriptives, chi-square, and independent t-test. With the tool development, the current Cardex had all essential information included except code status. That was the main thing that was missing. The Joint Commission has identified the inclusion of diagnosis, labs, age, allergies, plan of care, and recommendations for changes in care and code status as the essential information to include in handoffs to provide a framework to promote patient safety. Because the handoffs varied on each nursing unit, there was a need for consistency and standardization in the report process. Therefore, revision of the charge nurse report form from the Cardex currently in use by the charge nurses was necessary to incorporate the essential information that was missing, which was the code status. Revision of the report form to an SBAR format resulted in code status being routinely reported. So it was not only reorganization of the form, but putting it in SBAR format as well. Results of the statistical analysis of the chi-square test revealed that code status was more likely to be communicated using the revised report form. And once the revised report form was implemented, code status was reported 100% of the time. The independent t-test found significance between total report time of the Cardex and total report time of the revised report form. The revised report time mean time was 32.67 minutes compared to a Cardex report mean time of 42.11 minutes. Total report time using the Cardex was 75 minutes. Total time using the revised form was 58 minutes, so they became a little more efficient. Use of the revised form resulted in overall reduction of total report time by 17 minutes. The survey results, pre and post, showed that the charge nurses expressed overall satisfaction with training and the revised report form, and that they recommended team steps and SBAR training for all charge nurses. Discussion of the results involves examining the following 3 areas: essential elements of the report, efficiency, and debriefing. When looking at essential elements of report, handoffs varied on each nursing unit, which created a need for consistency and standardization in the report process. The charge nurses participated in the development of the revised charge nurse report form with 4 revisions until a final revision was acceptable by all charge nurses. Organization of the revised report form in SBAR format helped create a standardized format, ensuring that essential information would not be overlooked or omitted each time report was given. Lack of reporting essential information has the potential of jeopardizing patient safety. And this chart shows the use of SBAR as a means of standardization and identifies essential information to include in a handoff. And you see here under situation code status is highlighted as being essential information. Now let's take a look at efficiency. When we look at efficiency, we can see that the total time for charge nurse report improved from a mean of 42 minutes to a mean of 32 minutes, with a total decrease in report time of 17 minutes. Taking that into dollars, that's $879.80 yearly, or with looking at 19 charge nurses, the savings is $35,704.80. That cost savings can be translated into the salary of an additional staff person over time. So the time savings allows charge nurses more time to care for and address complex patient issues and to be more available to attend to staff concerns. Efficiency of charge nurse report was also affected by the type of report given. So there are 2 types of reports that were identified. Global, which is the initial report, and then condensed, which is the updated report. A global report provides an overview of all the patients. It's more detailed in content. It's delivered between charge nurses coming on duty after being off for more than 24 hours. And this type of report required more time to deliver. The max time for the global report was 58 minutes. The condensed report occurs between charge nurses who follow each other after 12-hour shifts. They come back to back. This type of report requires less time to deliver, and the minimum time for the condensed report was 15 minutes. The handoff is a significant aspect of nursing practice because it communicates information from one nurse or shift and formally hands over responsibility for patients. Due to the complexity and amount of qualitative and quantitative data delivered during the charge nurse report, the handoff process is a time for debriefing, especially if stressful events occurred during that shift. Debriefing was part of the charge nurse report ritual. And rituals are things that occur the same way at the same time all the time. So the ritual of the charge nurse report always took place at the beginning of the shift and was preceded by a period of social discussion, which I call the pre-report discussion. This interaction allowed the charge nurses to form an emotional connection, allowing debriefing and de-stressing of feelings before the discussion of patient information begins, thereby decreasing anxiety. Completion of this process is especially helpful during challenging and demanding shifts. Now let's look at some limitations of this project. 1 hospital, 3 units at 1 hospital, and the small sample size. Some recommendations for future study include addressing interruptions, report interruptions, and background noise. Even though there was a sign posted to alert staff entering the room that report was in progress, interruptions still occurred, but they were at a decreased rate. The recommendation is to have a quiet, dedicated place away from the main traffic area on the nursing unit using non-interruptive strategies such as putting a sign on the door or delegating staff to answer the phone during a report. Also, examining other report forms in use on the nursing unit to ensure that certain essential information such as code status is arranged in a standardized form such as SBAR, making sure that the standardization of the report process continues. Some conclusions. The results of this quality improvement project showed that increased efficiency, decreased duration of the handoff, and it also decreased interruptions. It increased the satisfaction with charge nurse handoff process, and it supported the importance of training charge nurses in the handoff process to promote consistent information exchange and improve time management. Okay, are there any questions? Or is this time for the response?
However you want to do it. Often we'll do the invited response and then take
Okay.
questions on it all.
Okay. Oh.
I'm going to stand out here. I'm going to talk to Pat, but I'm also going to talk to you all too. Okay. And I better warn you, I think most of you know me pretty well, so be ready. Pat, as you were talking, number one, I would like to say kudos, because the topic that you selected is, and yes, I realize it was several years ago, but the time and the topic are so imperative right now. So it's very timely and it's very important. But a question I would have right now for you and then for all of us is, we know it's important. We know that SBAR and team steps are important. Why hasn't it exploded? Why are we still having to push it? Anybody have any thoughts? We'd like to solve that, because it is a quandary. Okay, why?
It's the same thing as the patient safety. We've had issues with patient safety all along, and we know they're there, and everybody addresses them, and there are patient safety goals that have been put out, and all types of things have come around, but the problem still exists. Everybody knows the yellow gown means falls, but there are still falls. So it's similar. I don't think that we'll get rid of the issue 100%.
Anybody else have any thoughts?
Yeah, I think it could be a part of the organizational culture of resistance to change. This is the way we've always done it.
Change.
Yeah.
I think the word you put there is change. Okay, good, excellent.
Randy and I are in the same organization, and I'm new there. And they had been using a previous format and went back to a Cardex reporting system, and actually have gotten less efficient and effective at their shift handoff. So we're moving back to the previous system, which was a blend of computerized and Cardex together, because it brought them together to do the report. So they had
That's
actually...
kind of sad, because those Cardexes really ought to be in the SBAR formation. If you do that, then it doesn't really matter what you give the report off of if the Cardex is in the SBAR.
But the problem has come in with...
And that gets everybody's eyes on it too, not just the charge nurses.
And they're losing many things in the report. We have a huge disconnect in continuity. So we're going to try a blended format again and see if we can.
Okay.
That's where it's
So,
also kind of important to determine what the essential elements of the report are, so that everyone agrees on those elements and it's consistent amongst all areas.
And to me, it just kind of pulls right back to showing how important the research study was, and if we could take the data that was found and expand it and go with it. So that was number one.
I think that SBAR just has to be used on pretty much every kind of communication that is given between not just charge nurses, but the nurses, the doctors, everything. If we can just cut it down to using the SBAR, we cut out a whole bunch of our.
We could solve a lot of problems, right?
Yes, I
Okay.
don't understand the
Okay,
resistance on that.
and I'll just feed in what you just said, and it kind of builds on what Pat talked about. I just came from a conference, and it's always fun to listen to other people. And the realization that's out there for everybody, the move toward change in the hospital setting and looking at our communication practices needs to start in the schools, but needs to start in practice at the same time, because if that doesn't happen, we teach the students, they go to the hospital, what happens?
They pick up the bad habits.
Yeah, well, they pick up the bad habits, they come back to us and say, they don't do this in real life. So why are you teaching me? So it has to go laterally across. At the same time, though, it has to be top down, bottom up. In other words, administration have to say this is worth it, and the faculty have to say it's worth it. So it's kind of like this thing all at once, and that's so huge. It isn't happening because it's change, okay, the natural word. So kudos, Pat, okay? The other thing I hope you all picked up, she said my favorite word. Does anybody know what my favorite word is? Come on, you guys. I'm a simulation person. I love sim, but sim is not my favorite. It's part of sim is my favorite word, but my favorite word is, Pat, what did you say? Come on, you got what part of sim is where the learning takes, got it, okay, debrief, okay, that she literally said the word, that looking at, with them, that the exchange should be a debrief, okay? And I thought, wow, that is exactly what the NLN, National Council, has said to us, or the league has said to us, is we should be using the strategies of debrief more than just in simulation. We should be using those same strategies in the clinical setting and also in post-conferences. Okay, how can we utilize them? We don't have models right now out there. So while Pat was talking, I came up with our model, okay? So here we go. You thought I was just sitting here, didn't you? Okay, let me move. Our debrief for report. Reaction, okay? Always reaction. I think you really hit it on the head there. Is talk to me about how your shift was. How was your shift? Okay? You got to get the emotions out before you can move on. That also allows a little bit of socialization. And until people get emotions, there is an exchange. If I had a shift where things just went disastrous, I am not going to be thinking about how I need to give a report. But if you acknowledge my feelings and we can talk about it, wow, then I can move on. So reaction, analysis, that's where you stick in your S-bar in the format that you have. And summary would be my recommendations. These are things I think that you're going to need to follow up for me. Bang, 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 bang. Okay? So we got another project to go. Okay? So there's our debrief for a shift report. So what do I want to say? In a capstone real quickly, wonderful, very, very timely, but it can't stop, okay? Because you have a format there, utilized with X number of units. We know we still have a problem. So how do we solve the problems? We have to keep with the research and keep with our change, okay? Because what is the evidence showing us? We still have errors out there. We haven't solved the problem we've been working on a long time. So that's my back to you. Okay? So I'd say open it up to them, see what they say. I'll be down.
With your study, I mean, it sounds to me like you were doing like from a shift to shift,
Yes.
intra-department. What is your take, or during your research or doing this, what if you're giving a report intra-department? Like, I'm from peri-anesthesia nursing, from PACU reporting to the floor. Did you find anything there that would be helpful for that interchange, that patient report from a PACU standpoint to a floor or to an ICU?
There still would have to be still use the same Cardex, the same format, SBAR format that the institution has to decide on. That's the format that we're going to use. But essential elements of the report would be different going from unit to unit. So that's something that has to be worked out. What is essential for us to know from PACU going back to the floor? What's needed? That was the key thing there for these 3 units to sit down together, because they were different, all different, and come together on determining what was essential information that needed to be passed on in that charge nurse report.
Doctor,
Yes.
It seems like some of what you said, the important steps, would hold true even if it's PACU to floor. Because you still want to give that nurse an opportunity.
Yes.
How was to stay here? It might not be as long. Because
Right,
we're
right,
not talking
yeah.
about an 8 or 12 hour period, but.
It's still the essential elements would still be the same.
Or
You know,
even if it's radiology calling.
Yeah.
Or any department.
but that's something that still would have to be agreed upon. You know, what is essential? And that's what I had to look for in the literature, what was considered essential information for a report.
Was Joint Commission your only place, your source of truth, or what were your other source of truth for that information to be essential?
There were other articles that were out there too that talked about the shift change report, and so looking at that, plus looking at what the unit, these were med-surg units, so what is their focus? You know, what are we looking for? Drains. They all had to agree on drains. What do we ask for in report? And remember, the charge nurse report is different from the nurse to nurse report. And that's why it was chosen, because it is different. What you want to know is more global than the nurse to nurse, which is more specific to that patient. So the questions that you're going to be asking are different.
Thank you.
Oh, Carmen.
I just wanted to ask you, what do you believe caused the decrease in report time of the handout? Because that was a lot of money. And, you know, if you were an owner of a business or something, that looks
Well, you
good.
want that person back on the floor, being available to the staff,
Right.
because a lot of it was the team steps training.
Okay.
They were trained on how to communicate more effectively as team members.
So communication. was-
Yes, and that was, all of them had to attend the training, and that's why there were 5 training sessions to accommodate their schedule.
Did they address the social discussion as being a time waster?
Well, that was part of my observation, that I noticed that, and I kept noticing that when they got started, they had to start talking about whatever was going on, you know, in their life. And they had to get through that before they could get down to the business of report. You had to get through all of it. So you have to have that social, can't be all business. You have to be able to de-stress.
And one more question for you, Pat. Did you notice that the lack of experience in the charge nurse role had anything to do with how quickly
Yes,
they went?
yes,
Yeah, I thought
yes,
so.
yes. Yeah, the more, and in this case, the majority of the charge nurses were young in the role. So if there had been, in doing this and repeating this with more experienced charge nurses, they probably would be more efficient in the task. Yes.
Did you notice a difference in how the men charge nurses responded to and versus the women? Because you mentioned the social thing. I'm thinking when I go to work, I don't.
No, don't talk to me about it. I don't want to hear about what your kids are doing. Yeah. Let's get down to business so I can get out of here. Yeah. There was still a period of socialization, regardless, because they knew each other. I mean, they're friendly, and if they were coming back to back, I mean, the report went really they whizzed through it, or they could say no change, but they still had to go through the list of the patients, which took the 15 minutes. Whereas on the nurse to nurse, if you look at that on the floor, they can get through that in 5 minutes, you know, if you're following somebody after 12 hours. But because of the complexity of their role, you know, it took a little more time, 15 minutes, but that was the minimum amount of time for a follow-up report if I'm following somebody after 12 hours and I'm coming back. Yes, yes, sir.
It's always been my experience to use the S-bar as a component of the rapid response process.
Yeah.
So it was unique for me to see this as a debriefing instrument. Was there any problem with implementing that into the debriefing process?
No, because if you look at diffusions of innovation, the charge nurses were part of the change. So I didn't do anything, I didn't force this change on them. They came up with the elements of the change. So it was easier for adoption, for them to use it because they had input into the change. They were able to say, we want this and we want that. So they had to come to consensus though. So I was not the driver of the change, just the facilitator. Yes.
I was amazed that 17 minutes translated
Oh, yeah.
to $35,000.
Yeah.
That was just fantastic.
Yeah, it's a lot of money. Time is money.
Yeah, but I wondered also, did you have any major shifts in patient census that affected time? Did you have to adjust for that any? Or did patient census pretty much stay similar for all of those units?
Some of the units had more patients. One was had about 30, 40 patients, one had less. But the smallest unit was the one who were still audio taping. And the biggest change with this project, if nothing else, they stopped doing it. And then they became more efficient. But they had to start talking to each other. And so going through the team steps training helped them with communication.
That's such an important observation because, now in the whole evidence, as we continue to press forward with integrating evidence-based practice, it's not just pushing that which has a scientific basis, but it's removing that which is no longer
Right.
scientifically
Right,
based.
right.
And
That's the hardest.
that's the
Yeah.
hardest part.
Yeah.
Yeah, so.
And I think that was the unit that had the most change because they had to change. They had to get rid of the tape recorder, and they had to come in and they had to sit down and they had to talk to each other.
Well, that was part of the ritual.
Yeah, it was a ritual.
It's hard to do
Yeah.
rituals.
Yeah.
Was that unit a mix of more seasoned nurses or more younger nurses, or that was just, you're saying that was just the way?
It was just the way they were doing it, and they were the only unit that was doing that. Everybody else was doing a face-to-face report, a verbal report.
But if we go back in history, I remember when the audio came.
That was the-
and
that was the
to
norm.
Save time.
Yeah.
Yeah,
You
it's to
know,
save time.
I
Save
remember doing
time.
it
You
too.
could run in there and just punch the button, listen, take your notes and leave.
But that doesn't necessarily mean it's safe.
No, and it didn't save time.
It didn't save time.
It was innovative.
You had problems with that?
Yeah.
Years ago doing that.
This may be more of a comment than a question, but, when you're doing your SBAR handoff, I would like to wonder what the interaction was with the physicians during rounding. Were they able to communicate better now that they received it that way and also give it back to that physician upon rounding?
And it should be, they should be able to because they have everything's organized in a format that's more standardized. Yeah.
Been interesting.
Yeah.
Yes,
Yes, sir.
to what you said, my peri-anesthesia staff, they've gone through team steps, and their interaction with the physicians, their briefing between each other, and just interactions among it all. I can point to several different things that improved with their team steps training, and even as some of those nurses have gone, moved away out of the unit, that still has made a culture in my unit that has stayed even for the newer nurses that are coming in, and that type of training that you've done with this, doesn't really work. It's efficient.
Yeah. And even after, I did follow up after about 3 months, I went back to these units to see if they were still using the format, and they still were. Some of them were still trying to go back to their old ways, but, and of course change takes a little time, so, but they hadn't reverted back completely. So, and the tape recorder was not there, so I really wanted to make sure that was still in the trash. And they started using the language, huddle, briefing, handoff. They started using the language. And so I was real happy to hear that, so I knew the training was effective there. Any other questions? Yes,
I didn't
Lane.
hear the first part, so did you publish this? Is this published?
It's not published yet. It's, like I said, this happened like 5 years ago, but as Dr. Decker said, it's still relevant, so I just need to update my references, my resources, and publish it. It's still a relevant topic. Yes.
Do any other studies comparably tie what you've done to adverse outcomes?
I'm quite sure.
I don't
I
think so.
haven't seen any.
And I honestly don't think there's another study out there that talks about charge nursing.
No, it talks about nurse to nurse.
Nurse to nurse, but never that group of individuals. So it's a very unique.
And that's why I chose that group, because there was very little information on the phenomenon of that charge nurse to charge nurse report. Yes, sir.
Did you find a champion among your group? Were there two groups that you were working with, or just that one?
There were three nursing units in a med-surg cluster.
Did you have a champion among those?
The charge nurses became champions.
Okay.
They became the champions.
So that helped facilitate all?
Yes. Because remember in the diffusions of innovation, they're the change agents there to take the change on. Then you've got to find those first adopters.
Was there very much pushback with that?
Oh, no. Because there was buy-in by administration that we're going to change. And they allowed them the time off, and that showed the importance of doing this, giving them the time off to do. Plus, the Team Steps classes, I did a CE for that. I did the application, everything. They got credit for it. Not only did they get time off, but they got education credit. So it was a big deal for 4 hours.
Is it now a required educational process?
At some institutions, we are teaching, actually students are learning Team Steps in their education, in their nursing education, so they already have these skills when they go into practice. And a lot of institutions have adopted Team Steps as a way of communication and using SBAR as a standardized way of handing information off from between caregivers. And
Incidentally, that's what the senior students were doing today. We have Team Steps.
Yeah.
Talking to you.
Anything else? All right. Well, thank you so much.